So our first speaker is the Chief Instructor, Dr. Mohamed Faheem. He has done his fellowship in glaucoma from Arvind Eye Hospital, and he'll be talking about unlocking OCT potential, making the most of every OCT in optic nerve evaluation. Over to you.
Good afternoon, everyone. So we can start our IC, and the first topic is unlocking OCT potential, making the most of every OCT in optic nerve evaluation. Now we have a lot of OCT machines, so we'll try to decode each and every optic nerve disorders. So OCT we use as a low coherence near infrared light, and that is splitted to a reference arm and a sample arm, and the reflected light is detected and analyzed. And initially we have the time domain OCT in 1991. The resolution was less, and it will take more time where we use a moving reference mirror. Then in 2002, the spectral domain OCT came, where we use a spectrometer to analyze the reflected light. And in 2010, the swept source OCT came, where they use a sweeping light, a varying light between a small wavelength that is higher than the normal spectral domain OCT wavelength. So these are the three OCT machines, but the standard one is spectral domain OCT machine that is widely available, and there are a lot of OCT machines available. So we have the different mechanism. One uses the spectrometers, whereas the swept source have a changing sweeping wavelength. So time domain OCT, the axial resolution is usually less, 10 to 15. The older version have that, and the newer spectral domain OCT have a very good axial resolution. We can pick many finer detail using the spectral domain OCT. And the swept source OCT, the axial resolution is comparatively little lesser, but it is faster. It can take deeper picture, and it can analyze a wide field. And even in hazy medias, in cataract, it's very useful. But still, spectral domain OCT is the standard. And initially, we will be analyzing the optic nerve head. We have a lot of clinical signs to diagnose the glaucoma and the other optic nerve disorders. But now we have the OCT machine, and we can objectively and we can quantitatively analyze each and every parameters. The retinal nerve fiber layer thinning we can measure, GCC we can, ganglion cell complex we can measure, neuroretinal rim we can measure. So there are a lot of parameters available, and each and every day it is developing, and new things are coming. So this was the older time domain OCT, where they have only the RNFL data, and the spectral domain OCT they have the RNFL, and there are a lot of optic nerve head parameters, and the swept source OCT, which gives a wider image. So I'll be mainly focusing on the STOCT machines, and there are a lot of STOCT machines, and each one will be using a different machine. The first one is Zeiss Cirrus OCT, and the Heidelberg Spectralis OCT, the Optoview RTV OCT, Topcon 3D OCT. All these are standard OCTs, and we have an Indian version, Apasomi OCT, and many have that. And the Apasomi OCT is actually similar to the Zeiss Cirrus OCTs in many parameters. The normative database will be different, but altogether the structure is almost similar. And before diagnosing interpreting OCT, we should make sure that the signal strength is okay. And various machines have different signal strength, but it should be coming in a good signal strength range. Then only we can diagnose or interpret an OCT. And OCT have a lot of parameters, and one of the most important parameter is average RNFL thickness, which says whether it is normal or abnormal RNFL. And in the Spectralis OCT, we have the global RNFL value, and we have the normative database, less than 5%, less than 1%, and that they will give a color coded. The color coded thing will be available only for elder children, elder persons above 18 years. In children, we don't have the normative database. We have to compare from one to other, from one visit to other, whether there is any thinning occurring. And the first thing is retinal nerve fiber layer defect analysis that is present in all OCTs. So it has a quadrant wise or sector wise or clock-over wise, that varies with machine. You can see the Spectralis, where they have an RNFL map and a TSINT curve. And the TSINT curve in the Spectralis is very good. I don't have any financial interest. It's very good in Spectralis. And we have the Zeiss OCT, where that also gives the retinal for nerve fiber layer TSINT curve and the values, clock hour wise and the quadrant wise values. And coming the next thing we should look is area map. Normally we will look at the RNFL map, but we won't look at the area map. But area map will give a very clear information whether a retinal nerve fiber layer defect is there or not. You can see a retinal nerve fiber defect. The second one, the red thing, is the deviation map, but it is difficult to pick in the total in the thickness map. In thickness map, it is shown as a blue, whereas in deviation map, it will be shown as red. It will be shown in the red color. And the retinal nerve fiber defect is very clear in the fundus photo. And the next thing is ganglion cell analysis. That is also different. Some will analyze ganglion cell with inner plexiform layer. Some will analyze ganglion cell inner plexiform layer and the retinal nerve fiber layer. And some will analyze, especially spectralis, just a ganglion cell level. It varies with machine. We cannot compare one machine with other. And you can see the first one is normal, green, and you can see an inferior defect. And you can see a horizontal raphe signs, very clear feature of glaucoma. It obeys horizontal meridian, and that is very well documented in the Zeiss Cirrus OCT. If you use that, you can clearly see the horizontal raphe sign. And the ganglion cell layer analysis in the spectralis, this one is the normal and other one is having the inferior defect. So it will usually, all the parameters will correlate, try to correlate. And neuroretinal rim measurement is also varies with machine to machine. Some will use a reference plane. So you can see the base plane and the reference plane. Reference plane will be above around 120 to 200 micron from the base plane, and from that they will measure the neuroretinal rim parameters. Whereas the minimal rim width, the other machines like the newer Cirrus OCT and the Spectralis OCT, they will measure minimal rim width, the distance from the Brooks membrane opening to the internal limiting membrane. So both are different parameters, and we cannot compare. The values will be different. And the optic nerve head parameters, there are a lot of parameters, but the most important one is the rim area and the vertical cup disc ratio. And we have the TSINT graph for the retinal neuroretinal rim also. And in the Spectralis OCT, we will get a clear picture of the minimal rim width. It's a high resolution picture, and we can get many anatomical data of the disc margin. And one thing I have to emphasize is gray crescent. This was described by Bruce Shield in 1980. So this is actually, you can see the inferior portion, there is a pigmented gray crescent, and that we usually will be mistaken for glaucoma. And the inferior rim appears thinner. So with this OCT, you can see, we can clearly say that some Brooks membrane opening is encroaching, Brooks membrane is encroaching into the retinal nerve fiber layer. So that will give a wrong impression that the rim is thinner. So such details we can pick. And it has two types. One is the Brooks membrane will encroach onto the NRR, whereas in this case, a type K crescent where the hyperreflective choroid will encroach. All these will give a false impression of the outer border. You can clearly see the outer border is actually masked by the gray crescent. So always look at the gray crescent, and we can use OCT to delineate the gray crescent. And coming to some tips for interpreting OCT, optic nerve head, and retinal nerve fiber layer. Combine and correlate OCT parameter. Never use a single parameter. Always correlate. Here you can see the inferior neuroretinal rim is thinner. You can, in the area map, you can see the retinal nerve fiber layer defect. Coming to the thickness map, you need to focus clearly. Then only you can detect the RNFL. This is the normal picture. You can see the yellow and red regions. And you carefully see, you can see a blue region in the yellow region. So this is a nerve fiber layer defect. So actually this is one of the very sensitive marker to detect the optic disc retinal nerve fiber layer defect. And a recent study from Aravind say that this is the most important and early sign of early retinal nerve fiber layer defect. It is published in American Journal of Ophthalmology. And so they concluded thickness map is very relevant. So you should look at the thickness map, and you should compare it with the ganglion cell, inferior retinal nerve fiber layer thinning, and inferior ganglion cell defect. And this is the right side, and you should compare with fundus photo or HFA. HFA, sometimes it may not be reliable because only after 30% of damage, then only HFA damage will occur. Pre-perimetric glaucoma you cannot pick. But fundus photo is a good option. Compare it with fundus photo. Here also you can see even a thin RNFLD we can pick. And compare and correlate with you can come in the spectralis OCT also we can just compare this. And you can correlate with HFA when there is a definite glaucomatous perimetric damage is there. That is also a good option. But pre-perimetric glaucoma, it won't be useful. And the green disease and they will be discussed by Faisal sir. So just I will be telling one word about red disease. Some red things will be coming. Here actually it is normal OCT, but the shift is peaked. You can see the shift is peaked little towards the nasal side. So that's why we are getting an abnormal defect in the infratemporal quadrant. So always identify red disease and always try to identify the location and pattern of RNFLD. It should always correlate with the RNFLD. Ganglion cell and RNFLD defect should be correlated. But a temporal thinning with a diffuse ganglion cell thinning is not glaucomatous, is something different, and that will be discussed in the other instruction courses in the other presentations. And in myopia, it's difficult to diagnose, but you should keep in mind that in myopia, there will be a generalized thinning. That is not glaucomatous. And you should look for the RNFL distribution angle. That is basically the superior temporal and inferior temporal peaks will be shifted temporally. So that also, if you keep in mind, in myopic patients, it will be retracted temporarily. You will get an idea whether it is due to myopia or due to glaucoma. You can correlate with HFA in a proper diagnosed, proper definite case of glaucoma. Otherwise, it may not be useful. Ganglion cell is useful, especially an asymmetric ganglion cell. That will be one of the useful parameters to diagnose OCT in myopia. So with that, I will conclude my talk. Thank you.
Thank you, Dr. Faheem. That was